Welcome back. Well, today we have a couple guests from Hoag, and they are with the breast program over at Hoag, both down in Newport and up in Irvine. I'd like to welcome Heather McDonald. You are the medical director of the high-risk program, right?
Yes, I am.
And we also have January Lopez, who is the director of breast imaging with the breast program. Nice to meet you both.
Thank you.
So first, I'm going to ask you, January first, about the breast program in general, how Hoag operates this, and what it entails.
Okay, so the Hoag Breast Program really is a comprehensive program. So we know that breast cancer is very, very common. 1 in 8 women will develop breast cancer in their lifetime. Particularly in Orange County, actually, that number is closer to 1 in 7. So the experience that a woman has, from the time that they're diagnosed through treatment and after treatment can be very variable. But at Hoag, we have a full complement of services starting from the moment the woman comes in from her mammogram to the time she gets diagnosed, through her treatment and after treatment. So we have an unparalleled, really, level of resources available at Hoag in Orange County.
Okay, and Heather, you oversee the high-risk program. So
Yes.
How would somebody qualify for high risk? It's family history?
So family history is an important part of it, but there are some women that we can identify that we know they're at risk for breast cancer. Family history, and particularly first-degree relatives. So that would be mothers, sisters, daughters. Also, family history of ovarian cancer. Breast and ovarian cancer can run together. And so if there's ovarian cancer in a family, or a male family member with breast cancer, those are red flags that maybe there's an inheritable component to this, and that's someone who we would want to pay close attention to. Also, a woman who's had an atypical biopsy. So she's had a mammogram or a lump before, someone's done a biopsy. It wasn't cancer, but the cells weren't entirely normal. Cancer doesn't come out of nowhere. It starts with abnormal cells that progress to cancer. So if a woman's had abnormal cells before, atypia, that's another woman that we want to keep our eye on and offer her things that might even reduce her risk. There are medications that may reduce her risk, or maybe more intense screening.
Okay, so January, this is why mammograms are still important?
Absolutely.
And how often, depending on a woman's age?
So that's a very complex question, particularly for women who are over the age of 75. And the reason is that when you look at the data on screening mammograms, those studies were performed mainly in women who are 75 and younger. So the fact is there just isn't a lot of data in women older than age 75 and the benefits of screening. But there's absolutely no reason to think that mammograms wouldn't be beneficial for women over the age of 75. In fact, women's risk for developing breast cancer only goes up as we age. And mammograms on top of that are much easier to interpret when women are older because their breasts are less dense. So again, breast cancer risk, it's higher the older you get, and mammograms are our only tests that have been proven in randomized controlled trials to reduce a woman's risk of dying from breast cancer.
Okay. You mentioned something that's hardly ever mentioned. Men can get breast cancer.
Yes.
So how often should a man get screened for that? And I would assume it's something that you're really going to look at a family history where it's prevalent, and maybe some of the males, right?
Correct.
Because it's not talked about a lot, and yet it can happen, right?
Correct. It can happen. It is rare. So we don't have the same kind of trials that January mentioned about screening mammography for women and its effect of reducing your chance of dying from breast cancer. We don't have the same data for men because it is rare. But we know that it can be more common in families that carry the BRCA gene, particularly the BRCA2 gene. And so that's the red flag we're looking for. If there's male breast cancer in a family, what we want to do is find someone in that family who's had the cancer, see if we can get them into genetic testing. Because if that family carries a BRCA gene, then we really want to figure out who in the family carries it. For example, if my mother carried that gene, I would have a 50% chance that I inherited it, and therefore I have a high risk of breast cancer, or a 50% chance that I didn't inherit it. That's also true of men in the family. If my mother had a BRCA gene, my brother would have a 50% chance that he inherited it. We don't screen men routinely for breast cancer, so it's important to figure out who the men are who carry this BRCA gene, because we may need to screen them. Some of those men opt for mammography. Some of them opt for regular breast exam. But breast exam isn't even something we usually think about with men.
Right.
So if a man is at increased risk for breast cancer, he needs to be aware, his doctors need to be aware, so that we can find it early. Because the sad fact is, in men, it often isn't found early because we're not looking for it.
You know, speaking of that gene you're talking about, is that something more and more it's being screened for at a younger age? Do you think there's going to come a time when this type of genetic testing is going to be common and possibly even done for younger women or even when they're teenagers?
So I'll tell you, in the 10 years I've been in practice, gene testing has undergone huge changes. It's almost unrecognizable from what I learned 10 years ago in my training. It used to be we looked for basically 2 genes, BRCA1 and 2. Now we have 26, 49 gene panels where we understand so much more about the mutations and what we're looking for. Generally, we offer testing to families, to people in their early 20s, because in their teens, there often isn't really a risk of cancer. And the question is, would you want to know as a teenager that you're at risk for developing cancer when you're 50, when there's nothing you're going to do about it as a teenager?
Okay.
So usually we offer it to people in their 20s, because that is when we start intervening, we start screening. We'll start doing MRIs on women as young as 25 if they carry a BRCA gene and that cancer runs in their family. Mammograms as young as 30. So in the 20s is sort of when we really start thinking about it. Birth control pills become important to protect some of these women from ovarian cancer. So that's when we start testing, because it's when we would start talking about it and trying to mitigate that risk. But yes, I think it is going to become more and more common as we understand this better and better.
And January, explain the difference between a standard mammogram and 3D mammography. I know that's something that's being used more and more. Is it something that is used, the 3D mammography, all the time?
It's not used all the time, but the 3D mammogram is also known as digital breast tomosynthesis, is the newest and is really the best mammographic technology. So it's similar to a traditional 2-dimensional mammogram where it uses X-rays to create an image of the breast. But instead of one image of everything overlapping, it takes multiple different pictures at different angles and reconstructs it into 1 millimeter slices. So instead of looking through all the breast tissue, we're able to look through 1 millimeter at a time and find breast cancer smaller and kind of earlier. So the studies, there have been dozens of studies now on 3D mammograms, and they've shown that it improves our detection for breast cancer, for invasive cancers, by up to 40%, which is phenomenal. I mean, so much better.
So when do you choose to use that?
You know, it really benefits women, all women. But we're especially challenged in women with dense breasts or women who have had surgery. It can be much harder for us to detect breast cancer, and that added benefit of having the 3D really makes it easier for us. But all women, even women who aren't dense, even women who haven't had surgery, can benefit from 3D mammograms.
Going back to risks, what are some of the risk factors beyond you have a history within your family of that?
So the 2 major risk factors we mentioned, family history and an atypical breast biopsy or abnormal cells. But those aren't risk factors women can impact. You're born into your family. Whatever happens, happens. The risk factors that women can impact, they do not contribute to risk as much as family history, but they do contribute to a slightly increased risk of breast cancer, and it's the healthy living stuff that we all probably should do anyway. So exercise becomes important. Moderate alcohol use, which for women is less than average of 1 glass a day, so 7 glasses in a week. Smoking, which now really feels like common sense. You can add breast cancer to the list of cancers that are attributable to smoking. Healthy diets, limiting fat intake. All of those decrease your overall risk of cancer, but also decrease your risk of breast cancer as well. So some of it's common sense.
What about the symptoms that someone might have? Let's say they got a mammogram 2 years ago. Are there any symptoms that they can see at home themselves? Of course, you have breast exams. Are there any of the things that come forward where it might bring up a concern, where they might think to themselves, you know, even though I'm not scheduled to do this for another 6 months, maybe I should think about going in over the next few weeks?
Absolutely. So I think a breast lump is something that most women know to be concerned about. If a woman is still having menstrual periods and she feels a lump right before her period, she can wait till that period goes by and see if it persists. If it resolves after a period, it wasn't anything to be worried about. Bad things don't come and go. That's what makes them bad. They come and they just stay and get worse. So a lump that persists, I think most women know about that one. But there are others. If a woman notices skin retraction, and this often happens, maybe she's getting out of the shower, she's doing her hair, and she notices when she lifts her arm, some part of her breast pulls in. That's something to bring to a doctor's attention. We would do an exam, we would do a mammogram, we would do an ultrasound. We want to see, why is that skin kind of being tethered to one spot?
Okay.
It can happen from scars or surgical scars, but it can be a sign of cancer.
Okay.
A rash on the nipple is something she would want to bring to her doctor's attention, or fluid leaking from her nipple.
Okay.
Believe it or not, some of that is normal, but I wouldn't expect a patient to differentiate between normal fluid and abnormal fluid. I mean, breasts feed babies, so some fluid is normal even if you're not breastfeeding. But it can be a warning sign of cancer. So any of those things are warning signs to bring to a doctor. Breast pain is a common thing patient comes in with. Most breast pain is not related to cancer, but if it's localized to one spot and it's persisting, and again, it's not coming and going, it's staying, then that's something else that we would want to examine.
All right, great points that you brought up. I appreciate you both coming on and speaking with us today. And once again, January Lopez, she oversees the breast imaging. She's the director with a Hoag Breast Program, and Heather McDonald, and you are the medical director for the High Risk Program. The website is hoag.org/breast-program, as you can see right there. Thank you very much for coming on today.
Thank you.
We really appreciate it. Hope to see you again.
Pleasure to be here.
Take care, and we'll be right back. Great.